I'm going to talk about obesity, physical activity, and cancer in humans. So my talk is focused entirely on humans. And a couple of things to disclose, but I'm not going to talk about any medications, at least not intentionally. Just to give you an overview of terminology, so when I say physical activity or exercise, I mean the same thing. People, the experts in this area, have distinct terms for those, but please allow me to interchange those. And then body mass index is something that's been a measure that's been used in the study of obesity and overweight and cancer risk. It reflects adiposity and other mass. It's pretty good overall in a population. Somebody has a high body mass index, over 30, they're probably obese. But there are a few cases where somebody is very short or has a high muscle mass that BMI might not be a good indicator of obesity. And it doesn't reflect body fat distribution. That may or may not be relevant for some cancers. But usually most researchers are using a categorization of a BMI of 25 to 29 being overweight. If it's an Asian population, that marker is lowered. And if somebody's has a BMI of 30 or more, they're considered to be obese. And again, for Asian populations, then it's usually set at a lower level. And that's because those people have high risk of metabolic diseases. We don't know about cancer specifically, but metabolic diseases risk increases in Asian populations at lower BMIs. So first I'm going to review the epidemiology of BMI or adiposity and risk of several cancers, and then later I'm going to talk about clinical studies. So we know from epidemiology studies, and I referenced an excellent review by Renahan, that increased BMI is associated with increased risk for several cancers. And I've listed these off, but these are particularly breast, postmenopausal breast specifically, colon, endometrium, lower esophagus, and that's adenocarcinoma, kidney, and then several others that have been linked in a smaller number of studies, but linked to increased risk if an individual is obese or overweight. This is just showing this in picture format, so you can see that in men, this review, this meta-analysis found that for every 5 points increase in BMI, risk of several cancers increased significantly in men. And there are a couple that decrease, but that may be associated with some other lifestyle factors. But some of the most marked cancers, adenocarcinoma of the esophagus, thyroid and colon in men. And then in women, endometrium is very markedly increased with increased BMI, gallbladder, again, esophageal cancer, kidney cancer, and then breast cancer always shows up, but at a lower increased risk. Well, first I'm going to review a little bit of the epidemiology of BMI and breast cancer, and then I'm going to talk about weight change and breast cancer and other cancer risk. First I'll show you some data from the Women's Health Initiative. This is from the Women's Health Initiative cohort study that had about 93,000 women in it. These were women that were 50 to 79 years old, postmenopausal and healthy, and they were about 15% minority race ethnicity. And you can see these were measured weight and height, which is unusual for cohort studies. A lot of cohort studies are relying on self-report. And like in that cartoon that you saw before, people don't necessarily like weighing themselves or don't have access to a scale, so they may be reporting their weight from many years previous. But on the Women's Health Initiative, these heights and weights were measured. And we divided women at their baseline visit into quintiles of body mass index. And you can see an increased risk for those women who had never used hormone therapy, so there seems to be some effect modification. Those who had not used hormone therapy, increasing risk of breast cancer with increasing body mass index. And notice that it increases even at this normal weight category. So even under 25, there's some suggestion increased BMI at that lower level is increasing risk of breast cancer by about 50%. And this has been found in other studies too, like the Nurses' Health Study. What about weight change? Can an individual lose weight if they're already overweight or obese and reduce their risk of various cancers? Well, in the Women's Health Initiative, or the opposite, if women are gaining weight or people are gaining weight, are they going to increase risk? The Women's Health Initiative found that with increasing weight change from age 18 over time, you definitely see increased risk of breast cancer. So those women who had gained about 10 kilograms had the highest risk, about 70% increased risk of breast cancer. And again, this is seen in the women who have not used hormone therapy. That also has been shown, which I'll show in some other slides too. It's been shown in other studies as well. The Nurses' Health Study had excellent data that looked both at weight gain and also weight loss over time. And they found that regardless of hormone therapy use, that those women who lost weight had decreased risk of breast cancer, about 40% decreased risk. And you also see the same trend, a little bit lower trend, but increased risk of breast cancer with weight gain over time. In the AARP cohort of elderly population with 100,000 people followed over time, this is a strong suggestion of increased risk of breast cancer with increasing weight gain. They didn't see much effect of weight loss, but certainly see increased risk of weight gain. And this is for individuals, their lifetime weight change from age 18. One study, the Iowa Women's Health Study, was able to ask about lifetime purposeful weight loss. And there's a suggestion that women who lost 20 or more pounds over their lifetime had about a 20% decreased risk of breast cancer. Or if you combined all obesity-related cancers in that particular study, suggestion of a 14% risk reduction. On the other hand, another cohort study, a little bit smaller cohort study, but also was able to follow people for 6 years or more, found that those women who gained approximately 3 to 4 pounds in 6 years had increased risk of several cancers. So the data are not all consistent. And then in terms of risks for men, one study that followed men, the American Cancer Society study, followed men until they developed prostate cancer and looked at change in self-reported height and weight at 2 time points. And while there was not much going on overall for cancers in general, did find that some suggest a strong effect of reduced risk of prostate cancer in men who had lost weight over time. This is for advanced prostate cancer. So what about exercise? Overall, physical activity has been found to be associated with reduced risk for several cancers. I've listed them off there, but the particular ones are breast, colon, and a little bit of information on endometrial and lung cancer. And then other cancers through potential effects of exercise on reducing adiposity. This is a review from about 10 years ago, but it found quite a bit of consistency in the effect of physical activity on colorectal cancer. Most studies, almost all, finding decreased risk. So a little bit less consistency with breast cancer, but still finding overall a reduced risk of breast cancer with individuals who were the most active versus least active in those studies. A much more recent review in breast cancer reviewed the approximately 70 studies that have been published, and overall finds that there's about a 25% reduced risk of breast cancer in individuals who are very active compared to inactive. And overall, it looks like the greatest effect is in normal weight women. We don't have any information yet, however, on other types of activity beyond aerobic activity, which is the most common activity that individuals are reporting. So we don't know about strength training, conditioning, or non-purposeful movement, or alternative types of exercise like yoga. So this just shows in a picture format. Don't look at the individual studies, but if you can see this line suggesting no risk effect from physical activity, that most of the studies for breast cancer are looking towards the left side of that line, suggesting overall reduced risk of breast cancer in women who are highly active versus inactive. In the Women's Health Initiative, we asked women when they entered the study about their total physical activity, and we added all that data together and came up with a score of men hours per week. And that's just amount of activity multiplied by an intensity factor. And we found an overall trend toward decreasing risk of breast cancer with increasing physical activity. And we found that women did not have to do strenuous activity. They found no more effect with strenuous activity than with total activity. But when we divided women into the body mass index, so we had a question, is adiposity important? We found that indeed it was. The women who were obese were not getting much protection from physical activity. The only significant trend we found were in the women who were normal weight. So that suggests that both physical activity and maintenance of normal weight are important in reducing risk of breast cancer. Another excellent review or meta-analysis is being conducted in the UK, and this was published pretty recently, and this is looking at physical activity in colon cancer. Overall, they're finding about a 20% reduced risk of colon cancer in both men and women, and this is a review of cohort studies. Rectal cancer, however, no effect has been found overall, and some suggestion even of increased risk. When the studies that had data on amount of activity were reviewed, there is a very strong suggestion that the more activity the individual is doing, the greater reduction in risk. So a really good dose response effect for both men and women. More has been found in men, but definitely you're seeing it in both genders. So why could this be happening? How does adiposity and physical activity affect cancer risk? This is a very simplistic model that some of us are using to help explain why either adiposity or physical activity might affect the risk of various cancers. Certainly individuals who are obese have high levels of inflammation. They have high levels of insulin and insulin resistance, tend to have high glucose levels or be diabetic. And adipose tissue releases a number of substances, and I've only mentioned a couple here, but leptin is one possible obesity-related hormone that may be related, as well as adiponectin. And adiponectin is inversely related to degree of adiposity. For the hormone-related cancers, especially in women, increased estrogens and increased androgens may be relevant. And this is true for women. Men tend to have lower androgens if they're obese. But this, for those cancers that are related to high levels of estrogens or androgens, that may be another explanation linking obesity to increased risk of cancer. And this model is a little bit more complicated, but it shows a lot of the same things. This is a model taken from a review by Rundle et al., suggesting that physical activity can affect a lot of different body systems. One is hormones that I just mentioned for adiposity. Some suggestion it could affect immune function. In animal studies, physical activity affects growth factors, not so true in humans. And then there may be some other more downstream effects of physical activity on cancer risk or cancer development. So to look at the association of physical activity and obesity on some of these biomarkers that I just mentioned, in particular estrogens, we did a cross-sectional analysis in the Women's Health Initiative, and this was in a random sample of about 260 women. We divided women into high and low body mass index. It was above and below the median of 27, and then into the top and bottom levels of physical activity above and below the median. And we found that for estrone, the most common estrogen in postmenopausal women, that the women who had the lowest level of physical activity and the highest level of obesity had the highest estrone levels, and a similar association with estradiol, again suggesting that both physical activity and lack of obesity may be important in keeping these hormones at lower levels. So now I'm going to turn to clinical trial evidence, and that's where we can see if you make a change in a human, can you get effects on biomarkers that may be related to the association between obesity or physical activity and cancer risk. So in background, I already mentioned that for those models, but in epidemiology studies, we've seen that women who have high estrogen levels have increased risk of breast cancer. Women who have androgens at increased levels also increased risk of breast cancer. Some suggestion that elevated insulin levels may promote breast cancer, and then possible associations between inflammation and breast cancer. And these particular clinical trials I'm going to present today are all related to breast cancer, but some of these biomarkers may be important to other cancers as well. So we hypothesized that overweight and obesity and a sedentary lifestyle were associated with increased levels of these biomarkers, and cross-sectional studies have shown that, but we wanted to see with randomized controlled trial methods if change in these can change those biomarkers. So the first study was a randomized controlled trial where we recruited people from the general population. We randomized them into an exercise intervention, which was aerobic activity. Their goal was 60 to 85% of the maximum heart rate, and that means that their goal was moderate to vigorous activity. And the goal was 45 minutes a day, 5 days a week. We picked that amount based on observational data on physical activity associations with breast cancer. And this was both facility and home-based. And the women in a control group were given a stretching class. So 173 women were randomized. To be eligible, women had to be healthy, postmenopausal, age 50 to 75, overweight or obese, inactive, and not using hormones, not smoking, and drinking very little alcohol. And these last three, because these are related to estrogen levels. So what were these women like? On average, they were age 60. They were primarily non-Hispanic white. And their BMI was 30 on average, which suggests they were obese. And their VO2 max was 20, and that suggests that they were quite inactive. As I mentioned, the intervention the goal was 45 minutes a day, 5 days a week, and on average the women met about 81%, or 81% met 80% of that goal. So the mean was 171 minutes a week. And only 6 women stopped exercising, so we had really excellent adherence. And then the control participants, you may worry that controls would drop into your intervention. That didn't happen. Only about 6 women increased exercise at the level of our goal exercise. So on average, the women increased their fitness if they were in the intervention group and not in the control group, so that suggests the intervention worked, and that was measured through VO2 max. And I just want to show you how much weight. You don't lose much weight with exercise alone, and these women did not either. Their mean weight loss was about 1.5 kilograms, so that's quite typical. But they did lose weight on average, and there was some variability. So what happened to their biomarkers? We did find overall that we didn't see at 12 months much effect of the exercise program on the estrogens or androgens. But when we looked by amount of fat loss, those women who lost any fat at all, and that's measured by DEXA scan, had significantly decreased levels of estrone. Same thing for estradiol. Same thing for testosterone. And so really suggesting that fat loss, so obesity as well as physical activity, was important for estrogen levels and androgen levels in women. Then we looked at a marker of inflammation, C-reactive protein, and found some suggestion that women who were in the exercise group had a significant reduction. It doesn't look large there, but it was statistically significant reduction in C-reactive protein versus the controls. This is limited to the women who were obese, and those are the women that had high levels of inflammation. And I mentioned that early. Obese individuals have high inflammation levels, so those are the women that decreased significantly their level of C-reactive protein. When we looked at women who lost fat, so similar to the analysis we did with estrogens, those women who lost 2% or more of body fat measured through DEXA are the ones that we saw a decrease in C-reactive protein. And you see this much more marked in the women who are obese. So those are the ones who are losing, if they're losing fat, they're reducing their inflammation levels. Some other markers that are related to both obesity and cancer were found to decrease significantly in exercises versus controls. Part of that was because the controls went up over time, like many Americans are doing. The controls gained some weight, and they also gained some of these adverse markers. So insulin significantly reduced in estrogen in exercises versus controls. And home is a marker of insulin resistance, so that was also decreased primarily because the controls got worse. So we were so intrigued with the effect of reducing body fat on markers, but not as much effect of exercise alone, that we designed a trial to look at both reduction of body fat through a dietary intervention and also to look at exercise. So the goal was to look at both weight loss through diet and exercise on these same biomarkers in the same type of population. And so the goal was to test a 12-month dietary weight loss program and exercise interventions on these same biomarkers that I talked about for the last trial: estrogens, androgens, insulin resistance markers, and inflammation. Again, it was the same design in general as the last trial. It was a randomized controlled trial. We randomized 438 women. They were recruited through the general population, and they had to be the same eligibility as the last trial. So overweight and obese, postmenopausal, age 50 to 75. Women were randomized to one of these 4 arms. By design, the controls were a smaller group. So it was a dietary weight loss program or an exercise program, and this was the same as our previous exercise program, or combined diet plus exercise. And we had excellent retention, as you can see, with the number of people coming back for the 12-month visit. So this is a little bit busy slide, but just to show you that the diet was modified from the Diabetes Prevention Program, which is an excellent program that's been shown to reduce weight by about 7% over 12 months. Our goal was 10% by 6 months and then maintenance. And women had 2 to 4 individual sessions, and then the rest of the intervention was delivered in group sessions. And we had regular weighings of the individuals. We had individuals weigh themselves at home and keep food logs, and also we found that the women attended about 91% of their sessions on average. So excellent adherence. And the exercise intervention, the same goal as the previous trial, was 45 minutes a day, 5 days a week, 3 days a week at our facility and 2 days a week at home. And the same goal for intensity, it was moderate to vigorous activity, 60, a little bit lower than the last time, but 60 to 75% VO2 max. And our adherence, again, was excellent. 80% of the group on average, the groups in the exercise groups met 80% of their target. The women on average were 58 years old. They were primarily non-Hispanic white. On average, they were obese. Their body fat was 48% as measured by DEXA. Their VO2 max was 23, suggesting they're quite sedentary. And none of these baseline factors differed by arm. And we only had 9% loss to follow-up over 12 months. Really excellent follow-up. Just to show you what their weight did, the women in the 2 diet groups, one was diet alone and one was diet plus exercise, met or exceeded on average the 10% weight loss goal over 12 months. And again, exercise showed just a very small amount of change. This slide just shows the categories of change, but look down here, you can see that the greatest amount of weight loss was in the diet plus exercise group, where 60% of the women met their 10% goal. Well, what happened to their study endpoints, their hormones? Well, we found about a 12% reduction in estrone, that's the most common estrogen in postmenopausal women, in either the diet group or the diet plus exercise group. A little bit of an effect in the exercise alone, but really you see much more effect with the diet groups. Same thing with estradiol, over 20% reduction in estradiol in women in the diet plus exercise group over 12 months. Testosterone, you see some trend, but primarily as the only significant difference between exercise and between intervention and control was in the diet plus exercise group, but it's a much smaller change, only about a 7% reduction. Sex hormone binding globulin increased, but this has been seen before in other studies. Dietary weight loss does tend to increase sex hormone binding globulin, which is the most common binding globulin for estradiol. When we calculated free estradiol, we found about a 30% reduction in free estradiol, so that's thought to be the most active in diet plus exercise group. Same thing for free testosterone. We then looked by amount of weight loss. So even though the women lost on average 10% weight loss, there was some variability. So we looked at those women who lost more or less than 5%. And found you really see some trend there. Those women who lost less weight, even in the diet groups, really are not losing nearly, you're not seeing as much of a reduction in these serum markers. You really see much more in those women who lost at least 5% body weight. You see the same thing for estradiol and for all of these markers. So the same trend. It's really the women who are losing at least 5% body weight that you're seeing some change. So moving on to a couple of the other markers that I mentioned for the other trial, we saw a significant decrease in insulin, but only in the weight loss groups. And we saw similar effects on some other insulin-related markers, either HOMA or C-peptide. And then for inflammation, we saw a really marked effect, and this is something that's really, there are not many medications that can produce this amount of effect and change in inflammation. But we found those women who are in the diet plus exercise group or the diet alone really see very large decreases in levels of C-reactive protein. So almost over 45% reduction in C-reactive protein in the women in the diet plus exercise group. Serum amyloid A, which is another marker of inflammation, showed a very similar effect, but but smaller degree, 24% reduction. Interleukin-6 is in some studies has been related to cancer risk, also about a quarter reduction in interleukin-6 in the diet groups. Leukocytes, which has been associated, women who have high levels of leukocytes, and those are white blood cells, and we've seen this in the Women's Health Initiative, have increased risk for several cancers for unknown reasons. It's a marker of overall inflammation. And we did find decrease of about 10% levels of leukocytes in women in the diet plus exercise groups. And this was not accounted for by hemodilution, so the hematocrit did not change, but white blood cells did. So in conclusion, we've seen through these, the review that I mentioned in the beginning, that you see reduced risk for several cancers associated with keeping normal BMI, lifetime weight maintenance, and also increased physical activity or exercise. We've also seen that mechanism studies support biological effects of weight loss and exercise relevant to cancer, but there's still a lot of unanswered questions for risk reduction. And one question is how much weight loss is needed. Our study suggests that 5% weight loss can reduce some of the biomarkers of cancer, but certainly we don't know about all biomarkers of cancer. And there's been very few observational studies that have looked at weight loss over time and risk of cancer. We don't know about the effects of different weight loss methods on some of these biomarkers. We don't know about the amount and type of exercise needed, and we don't know much about specific populations like minorities or high-risk populations. So thank you. If anybody has any questions.
Comment? Question?
Yeah. That was a very interesting talk. Max Wisher from Ann Arbor, Michigan. One comment, we've been looking at stem cells, both normal and initiated stem cells in the breast. And one of the key regulators of the stem cell and the relation of inflammation is IL-6, as you mentioned too. So one interesting hypothesis is that diet and exercise through IL-6 is actually regulating these partially initiated cells in the breast. Would be certainly a very interesting topic, to be able to look at if we had some way of trying to monitor that.
Well, thank you. Yeah, and one thing that still is missing is the effect of any of these interventions on the breast directly. And that's something we're going to try to do more in the future.
Matthew Young, the NCI. Are there any adverse effects of lowering these biomarkers? And if not, why aren't we using them as biomarkers for weight reduction and better health, especially for our women?
The effects of lowering some of those biomarkers have not been shown. So is it bad to reduce your C-reactive protein? I don't think anybody's shown that it's adverse. And certainly reducing insulin levels within, as long as the individual is still making insulin, is thought to be beneficial. In terms of estrogens, there are certainly suggestions that estrogen levels, if they're low enough, will increase risk of fractures. We've found in our studies that with our level of estrogen decrease, we're not seeing any adverse effect on bone density as measured by DEXA. So it seems that the aromatase inhibitor effects, which reduce estrogen levels to 0, do increase risk of bone fractures or osteoporosis, but we're not seeing that with this level. Measuring things like estrogens in postmenopausal women as a marker of obesity change is very difficult because most labs can't measure this with accuracy. Labs can certainly measure C-reactive protein and insulin, and a lot of people are using those clinically, at least for cardiovascular diabetes risk.
Thank you for the talk. Arasha Tamadi from NCI. My impression was that mainly we're looking at weight reduction and adiposity reduction as the main outcome. I mean, the main thing that mediates these effects that you saw. I have two questions. One was, in the second trial, did you also look at insulin as in the first one? And the second is the CRP levels, which we saw that were markedly decreased in the exercise plus diet group and also the diet group. Did you also stratify, like the other analysis, for weight loss and also adiposity or whatever you measured? Thank you.
So the first question, did we look at insulin? And yes, insulin decreased significantly by about 20% in the two diet groups in the second trial. In terms of stratifying by amount of weight loss, yes, we've done that, and you do see some sub-trend, and those analyses are ongoing. Thank you.
And is it working? Does it work? Now it works. Sorry. Oh, I didn't see you there. But I'm going to answer the question anyway. You know, this whole issue of this 5% reduction that you talked about would be ideal. I assume that depends on where you're starting. So if you're starting heavier, that's a 5%. If you're closer to that ideal weight, it's less than that? Or do we have that kind of information?
Well, when we look at, when we stratify by the person's baseline body mass index, just by gross categories, we still see the same effects in both in the overweight to obese and the obese level. And yes, you do see more weight loss. If you're looking at a 5% marker, it's more weight loss in the heavier women, but it's a very good clinically used marker, and it's used in the diabetes field, which is one reason we used it. But looking at amount of weight loss or amount of fat loss through DEXA, or looking at percent body fat, you really see the same kinds of trends.
So while I noticed that there were often synergies by having exercise and diet together, the greatest impact was actually dietary restriction, right? So is that our bottom line? That's the first thing that one needs to deal with is caloric restriction?
Well, certainly for getting a great amount of fat loss, or body fat loss, but we did see that the diet plus exercise group are the ones that really lost the most weight, and that's where we see the largest effect. It was marginally higher, though. So if you're going to get somebody to do something, I would start with calorie restriction or lowering calories to get weight loss down. However, we know from the weight loss community that long-term weight loss is best achieved through both calorie restriction and physical activity. So I wouldn't recommend overall, in general, that people only do weight loss through calorie restriction. You're going to have to include physical activity for long-term benefits.
Diane?
Yeah, Diane Burt, Iowa State University. I particularly was interested in that difference between the exercise group and the diet plus exercise group. What did you tell your exercise subjects? Did you tell them anything about not trying to compensate by eating more, or did you just kind of let what happens happen? If you exercise more and, you tend to eat more.
So for the exercise-only group, we asked them not to change their diet. And we did have, for the diet groups, we had them meet separately if they were diet-only or diet plus exercise to try to reduce the amount of crossover. But it's difficult to tell somebody, don't talk about exercise or don't talk about diet, because then they're going to want to do that. So, but we did try to separate as much as possible.
Last question.
Zhong Jianzhu from Colorado State University. I think my question already similar to Dr. Miller about compared to exercise. It seems that dietary intervention have more impact on our parameter you determine. So could you comment about that?
I think the biggest effect is weight loss. And so you see much more weight loss with calorie restriction than you do with exercise. We've shown in these two trials that weight loss is only about 1.5 kilograms over a year with exercise alone. So you really have to do calorie restriction in order to lose a significant amount of fat. And I think that's what's driving these biomarkers is the loss in body fat. But we know, as I mentioned, long-term reduction in body fat, maintenance of weight loss is best achieved with physical activity added. So I would never suggest that somebody do only calorie restriction for changing biomarkers.
Thank you.
Thanks.
Very short.
It's important to prevent cancer, but it's actually perhaps even more important to prevent risk of death through overall consideration of disease risk reduction. And I wonder if the NIH has considered the overall impact of an intervention on overall disease risk.
I think somebody from NIH needs to answer that. From my understanding, there's never
Absolutely.
been...
And honestly, I think that there is even greater attention these days to looking at the impact on multiple disease conditions that might be influenced by diet or exercise. So absolutely, that's occurring.